I heard the roads, the traffic is, it's out there already, so. And then Vernell, do you want us to wait for Edward?
No, I think we can go ahead and get started. Want to be mindful and respectful of everyone's time. But just you can keep an eye out for him if and when he joins. Thank you.
Yeah, great. We're gonna let everyone in as they come in. So here, we'll just get it started. Welcome. This is the County HealthNet Meet and Greet to kind of do a overview of CalAIM and the MOU and how HealthNet is leaning into servicing the children, youth, and families population that child welfare serves. Just a quick introduction of some of us. So I'm Beljeet Hundal. I'm a CalAIM consultant that has been brought on by CWDA and CFPIC. And so been working with both organizations to get into the space of CalAIM and assisting counties with that as well. So I'm going to turn it over to Diana, and then we'll go to Andrea.
All right, Diana Boyer, I'm the Director of Policy for Child Welfare and Older Adult Services at the County Welfare Directors Association. Thanks to everybody for being here today.
And I'm Andrea Sobrato with CFPIC, and I also have Laura and Peter here from CFPIC. Hello, everybody.
Great. So just real quick, I'm just going to bring up the agenda just so that we can review that. I did share that out in the email this morning. So HealthNet is going to do a presentation. There is a PowerPoint slide deck. If you did not receive that, we'll put it in the chat, and then we'll probably pass it out again after the meeting. As you have questions, we can either do it as they come up in the presentation, or you can just add them to the chat, and we monitor the chat. And if you don't feel we look to see if it's time to bring it up during the presentation, or we can leave it till the end. And we're going to facilitate a question and answer period as well. We are also going to ask counties to help us by participating in a quick 6-question survey after this, just again to make sure that we're meeting your needs through these meetings. And if there are additional ways that we can continue to support you as you lean into CalAIM and this partnership with your managed care plans in your county. So with that, I'm going to hand it over to Vernell with HealthNet.
So yes, good afternoon, everyone. My name is Vernell Shaw III, Director, Medi-Cal Regional Lead with HealthNet. I want to thank you all for joining today's discussion. Thank you for taking out the time to engage with HealthNet around this important topic. And for all of the folks on the call who are engaged with representatives from HealthNet in MOU discussions, I thank you for your time there, because I know those are very meaningful conversations that are happening. With that, I will pass it to my colleague, Nancy. Nancy, you can introduce yourself, and then we can jump into the PowerPoint. Thank you.
Thanks, Vernell. Hi, good afternoon. I'm Nancy Wong-Pipat-Kalev, Senior Director of Systems of Care at HealthNet. And really my role in the Systems of Care team is around strategy, development, program design, and implementation, and evaluation for our CalAIM and other programs that touch our members. I'm happy to be here, and thank you for inviting us. So with that, I'm going to ask Ariana to share screen, and we're going to go right into our presentation. We really try to keep the presentation as brief so that we can have more Q&A. We did focus the presentation more on a couple of programs, key programs within CalAIM. There are several programs that are part of CalAIM, and I'll share here. And if you'd like more information, we'd be happy to share and expand on additional programs that we didn't touch on today. So let's see. So we're going to cover enhanced care management, community supports, the child welfare liaison scope and functions, as well as the MOU. So that's really going to be our focus. And it looks like we will have time, much time for discussion. So if there are any other topics that we're not covering, please bring them up here. We want this to be an engaging discussion. All right, so Little bit of background on HealthNet. We are part of Centene Corporation, and that was as of 2016. And so that is our parent company. In California, we are HealthNet. In most of our counties, Calviva Health, we're the administrator for the local initiative in Madera, Fresno, and Kings called Calviva Health. And then in Imperial County, it's Community Health Plan Imperial Valley. But you can see in pink is where we are HealthNet. So we are in 14 counties. We serve over 3 million members, 2/3 of whom are Medi-Cal. So that is most of our membership. We've been in the Medi-Cal space for over 25 years, and this HealthNet has been around for about 45 years of that. And we are also a network model. So we contract with 90,000+ of our provider network. So that's hospitals, PCP, specialists, and then of course our CBO community providers through CalAIM and other providers. We employ a little over 5,700 employees between HealthNet and Centene that covers the California business. And we've also had an intentional focus on culturally responsive care in terms of our NCQA multicultural healthcare distinction that we had achieved back in 2011 when that recognition became available, and then really leading up to the NCQA Health Equity Accreditation, which has been a priority for us in serving not only our Medi-Cal members, but also our Medicare, commercial, and all of our lines of business. Next slide, please. Next slide. Thank you. So, Medi-Cal, so CalAIM, which is also called Medi-Cal Transformation, you'll hear that as sort of the new name for CalAIM, which is California Advancing and Innovating Medi-Cal is what CalAIM stands for. It really is sort of a phase and implementation through 5 years. So starting in January 2022 through 2027. And so a couple of the programs, so Enhanced Care Management or ECM, was one of the core programs that became funded and part of a new benefit that health plans cover and reimburse for, and then community support services as well. So really starting in 2022, and that's what I'm going to focus the presentation on today. ECM essentially provides whole person care. So care management for not only physical health, but behavioral health and social care all together across various systems of care for the member. And what community supports is essentially services that address social needs. So health-related social needs such as food and housing, sobering center services, asthma remediation. So services that address social drivers of health are now becoming benefits and paid for through the health plans. And what that means is we work with our community providers to provide those services and to reimburse our community providers and CBOs and county providers directly as part of our Medi-Cal network. Family therapy benefits also became a new service through the health plan that are available for those 21 and under, and that's before a mental health diagnosis is required. So that's really the key factor of family therapy, in that we're not requiring a diagnosis for these services. And CalAIM has expanded a wide range of non-specialty mental health services that were not covered by the health plans in the past, which now we are covering as benefits. Dyadic care is another really meaningful service for our members, particularly in terms of providing well care visits and behavioral health care between the caregiver and the child, and which is the dyad, right? Dyadic care. So recognizing the critical role of the child's caregiver in promoting healthy child development, and also in promoting behavioral health and social care. And so this is also a new service, a new benefit that you can tap into for your Medi-Cal members, as well as community health worker benefits. So community health worker services has been around, for decades, right? Through the county agencies, through CBO partners, and now we are actually contracting with those network of providers to reimburse them, to pay them for the services. So there's sustainability and funding, right? Not just relying on grant funding or periodic funding. Now through Medi-Cal, we're reimbursing as benefits. So the covered services for CHW workers are health education, health navigation, screening and assessments, and individual support and advocacy. Next slide. And if anyone has any questions, please just jump in. I can't see if someone raises their hands. Thank you. Under Enhanced Care Management, or ECM, this is the eligibility criteria. So essentially, later in the slide, you'll see the range of populations of focus is what DHCS calls, or what we know as target population, in our public health world. And so children and youth who meet one or more of the following conditions or under child welfare will qualify for enhanced care management. So those who are under 21, currently receiving foster care in California, those who are receiving also outside of California within the last 12 months, have aged out of foster care to age 26. So those transition age youth, those who are under 18 are eligible for or in California's Adoption Assistance Program. And then those who are under 18 from California's Family Maintenance Program within the last 12 months. And so really a wide range of children and youth who are under child welfare would qualify for ECM. Next slide, please. And I think, one of the questions that come up is, is this ECM may sound duplicative to what may be already being offered, within the child welfare system. And ECM is intended to be that air traffic controller, is what DHCS, I think, has kind of coined the term, as that single point of accountability to ensure coordination across multiple systems of care. And so, we know that children and youth are often engaging with multiple systems of care. And, if you look at sort of the different populations of focus or needs, there is overlap. And if you can go to the next slide, there's a little bit more context on. Actually, I probably should jump to, let me go to community supports, and then I'll go back to enhanced care management. CalAIM's community supports, I mentioned, address the social drivers of health. They are supposed to be medically appropriate and cost-effective alternatives to what we cover, through Medi-Cal, essentially. And right now there are 14 pre-approved, DHCS-approved community support services that health plans can opt in to provide, up to 14 of these services. HealthNet and CalViva Health and Community Health Plan of Imperial Valley has opted to implement all 14. So we have a network that provides all 14 services now, from housing, transition, tenancy, deposits, all the way down. And I'm going to provide a brief description of what they are. If you can go to the next slide. Okay. So, and I took this from what we share with our members, and we have this translated into all the threshold languages, and also tools for providers as well. We'll share that with you. So housing transition and navigation, essentially those who are at risk for homelessness or experiencing homelessness, housing transition and navigation support helps the member look for housing, right? And to get all the paperwork necessary. And this service can actually, last over a year depending on their needs. Housing tenancy and sustaining services is sort of, once they're housed, but they're at risk for losing housing. So there's also support for the Medi-Cal member to maintain housing through housing tenancy and sustaining services. So that those services are now available through CalAIM, as well as housing deposits. So we reimbursed up to $6,000 in housing deposit per member for security deposits, for first month's coverage, for essential items, to get a bed, refrigerator, and so forth for the actual application process. And so that is also a service now that is available to all of your Medi-Cal members, within our health plan in all the counties. Recuperative care, as well as short-term post-hospitalization housing, are also available for those who are in need of sort of temporary housing support to recuperate, from hospitalization or acute psychiatric, care need. And that's usually up to 90 days. And then they can go into short-term post-hospitalization housing for up to 6 months. So really helping address those who are experiencing homelessness or housing insecure who have a need for these services. Respite services is also a service, and I do have a slide with a little bit more details because Baljeet, I know you had asked for a little bit more information on respite services. So that is now also a covered community support service for all of our members in all counties, as well as sobering center services. Next slide. Asthma remediation is a big one for children and youth as well as adults. So we reimburse and have contracted with asthma remediation providers essentially to make physical modifications to the child or youth's home, right, or to the Medi-Cal member's home if they need mold mitigation, a HEPA filter, various physical items needed to mitigate their asthma triggers, and we'll reimburse up to $7,500 worth of work, whether it be mold abatement or getting in a HEPA filter for those who qualify for the services. Similarly, for home modifications, which is the third one down, this is also a physical modification into the home. If someone needs a ramp or a physical modification that will help them live in a sort of a healthier and addresses any health concerns. Day habilitation program is also a service that could be in a group setting or individual to help with sort of life skills, right? So for transition age youth, we have some of our providers who are providing group day habilitation services to help look at college applications and to apply for jobs and and so forth. Medically tailored meals and medically supported foods is also a new service now. So we provide up to 2 meals a day for up to 26 weeks, and really depending on their need. And so there are criteria for providing either the medically tailored meals or the healthy food boxes. That's also now a service. Nursing facility transition diversion to assisted living facility, as well as community transition services to nursing facility, is also a service now. This may not be as relevant to the child welfare population focus. It is something that is available for those who can benefit. And then lastly, personal care and homemaker service is also part of the 14 community support services that we have contracted out to provide. And Vernell, if you don't mind, I know there's some questions on the chat. If you can help respond and then I can look at it later as well. Thank you. Respite services. So respite services is essentially a service for the caregiver. So they're provided to caregivers of the members who require intermittent temporary supervision. I think, it's the same service that I think you're all familiar with, through other benefits. And now we are providing this as one of the 14 community support services. And we'll provide it to augment, and this service is not meant to supplant any current benefits or services that the child or youth is currently getting, but it is meant to really augment and provide any gaps in care. The respite services will need to be either in the home or it could be in a facility. So it could be a facility respite service that's approved through an approved out-of-home location as well. Members, in terms of criteria, they're members who live in the community and are compromised in their ADLs, activities of daily living, and dependent on a qualified caregiver who provides most of the support, and who require caregiver relief to avoid institutional placement as well. And you can see what DHCS has called out in terms of other subsets. Children who previously were covered for respite services under the pediatrics palliative care waiver also qualify. Foster care program beneficiaries, members enrolled in CCS or genetically handicapped persons program, and members with complex care needs. Okay. So, and I probably should have put this after the the initial ECM presentation. And so I'm going to jump a little bit, and I have a couple more slides before transitioning it to Vernell. In terms of the comprehensive care plan. So this is part of enhanced care management. If care management plans for ECM should include physical, mental health care, substance use disorder care, oral health, social supports, and SEOH care. For some of these services, it may seem like it overlaps with your current care management programs, and which it may, right? So it's really important to be able to coordinate with ECM providers to manage any gaps in care that your other care management programs are not covering. Children do not have to be enrolled in ECM to qualify for CS services. It is also an important call out. And this is a visual just to show that you could have a child enrolled in ECM along with the healthcare programs for children in foster care and also the California Wraparound Case Management Service components. So what's important is to identify any gaps in care whereby if, let's say, one of the case management program is not able to really focus on certain elements of care coordination, that's where the ECM provider can come in. And I think it's also important to note that DHCS is encouraging, and health plans are encouraging as well, the county agencies who are providing, these child welfare related case management services like the HCPC, FC care management, and the wraparounds to actually become ECM providers. So you're getting reimbursed for kind of the full wraparound care. You'll get reimbursed for ECM as well as your other current case management programs, right? That's ideal, so the child does not have multiple case manager, but you have an opportunity for that additional reimbursement through the health plans. Next slide. So this shows the eligibility or the population of focus that are now offered ECM services or could be eligible for enhanced care management services. And this is an important context for if you have caregivers of the child or youth who would also benefit for ECM from ECM, and they could be the same provider group, right? It could be, Didi Hirsch, who's one of our ECM providers, who then can provide ECM services to the caregiver as well as to the child. And so the caregiver, you can see it with adults, those experiencing homelessness or at risk for, those who are at risk for avoidable hospital or ED utilization, which includes behavioral health as well, those with serious mental health and substance use disorder, those transitioning from incarceration, so adults and children and youth, and other populations of focus here would qualify. So I'm going to turn it to Vernell now to continue.
Yes, thanks. Thank you, Nancy. I appreciate it. And so just, in line with what much of Nancy has already shared, coordinating care across the existing systems for these children and youth, right, is something that is supported by CalAIM. And I just kind of want to emphasize supported, right? Like there may be some instances where care management or case management team in play is really poised to continue to be the lead, right? And so ECM is not intended to supplant any program that, just from a care coordination and collaborative standpoint is poised to lead. It's really meant to be supportive and supplemental where it can be. So what you see here are a few of those programs where there are case management or care coordination services being offered, intensive care coordination through county mental health services, California Children's Services, child welfare public health nurses, family maintenance, child and family team meetings, to some extent, independent living programs, and adoption assistance. So here we're just sort of flagging some of those programs that we recognize and acknowledge have care management, care coordination components to it. And really the managed care plans are responsible for ensuring that there are no non-duplication of services, and in so doing, right, will identify or work with you to identify which program makes the most sense to continue to be on point or on lead. Next slide, please. You know, again, here ECM can support the entire continuum, right? So a couple of examples of how ECM and CS can fill service gaps, right? So currently or previously in foster care, as Nancy has discussed in the eligibility criteria. A few examples, and I won't read through them all, but provide coordination with primary care provider and the health plan, coordinate supportive care, extracurricular activities to build relationships between the caregiver and child, et cetera. For family maintenance, case management, and supporting connections to economic and other community services. You know, Nancy touched on enrollment in community support, such as medically tailored meals and asthma remediation. And then, you know, to support with, you know, enrollment of caregivers in ECM, provider continuity of care after family maintenance cases closed, et cetera. For adoption assistance, similar aftercare, right? And care coordination to support adoptive families, ensure health and, ensure health related services are received and monitored, and support enrollment in community supports, again, such as medically tailored meals and asthma remediation. Next slide, please. So what we wanted to flag here is a current opportunity, right? The new guidance from CDSS anticipates child welfare agencies will begin implementing CFTs for families, for all families in voluntary and court-ordered family maintenance programs beginning January 1, 2025. We recognize that some agencies may already be supporting their dependents and families with CFTs already. The current 2023-2024 funding available for county readiness and workforce training activities are also available to support anticipated implementation of these family maintenance CFTs. And beneath the text at the bottom is a link for just more information on what's available here through this opportunity. Next slide, please. So why are we really raising this? To really highlight that you can support families in accessing eligible benefits, right? You know, complete the ECM referral form and send it to the managed care plan, or connect directly with the local ECM provider, right? Members can also self-refer, right? You know, we acknowledge that through some of the MOU discussions, through some of the work that will be done under the joint collaboration for establishing policies and procedures, there may be opportunities to work in, you know, ideas around sharing, you know, beyond the identification of the child welfare liaison and beyond the identification of the MCP child welfare liaison. There may be opportunities to share contact lists, right, between the health plan and the county to identify child welfare workers, to link child welfare workers directly with ECM providers, and designate or create workflows between the MCPs, the ECM providers, and the child welfare social workers, just to ensure that there's proper connection and that inquiries are responded to in a timely manner. Members can also self-refer, as I said. Once enrolled in ECM, an ECM provider can reach out to the county child welfare social worker for care plan information or to advise of the ECM enrollment and assignment. And again, as I said before, the MOU work, the current discussions, the negotiations, the work that will be done on the policies and procedures, the workflows, is just another opportunity to include much of these necessary details. So the call to action, right, is to help us identify eligible children and families, right? Children and youth involved in child welfare are eligible, period. Family members, caregivers may be eligible, and you will work with health plans, work with, you know, reviewing the eligibility criteria that is available to everyone to support determining whether that is the case or not. Work with your local child welfare county regional office to do some of the following things that are listed here, right? Present at upcoming monthly meetings, map the current practice and process for fee-for-service versus managed care plan enrollment, explore referral pathways to ECM providers in your service areas, and also connect with your local ECM providers. Okay, next we're going to get into some of the scope for the Child Welfare Liaison. So HealthNet will have a team of individuals designated to serve as the Child Welfare Liaisons for all of our service area. As is required by DHCS, as is called out in the MOU, additional liaisons will be added or designated to the team as needed to ensure that the needs of children and youth and families, right, involved with child welfare are met. The HealthNet Child Welfare Liaison will follow the DHCS issued standards and expectations, right? So whether that's, you know, the language in the language in the MOU or language in the APLs or either any future guidance provided by DHCS, right? HealthNet will be in compliance with that, and so would the Child Welfare Liaison. So they will, at a minimum, right, have experience working with child welfare services and county behavioral health services, understand the processes and protocols to ensure appropriate ECM staff, including the ECM lead care manager, whenever possible, attends child and family team meetings. And in some of the discussions that we've been having at the local county level, you know, we're having discussions around the county child welfare taking the point on advising the health plan when and where would be the best CFT to have the ECM lead care manager, or where and when would be the best CFT to have the child welfare liaison, the MCP child welfare liaison attend, right? So we acknowledge that, but are also willing to do it in accordance with relevant welfare and institution codes and sections, and just to ensure that all covered services are closely coordinated with other services, including social services and specialty mental health care services. The Child Welfare Liaison will ensure the streamlined coordination of ECM and covered services to child welfare involved children and youth, right, by providing technical assistance as needed and serving as the MCP point of contact for escalations to support the resolution of any operational obstacles. They will be sufficiently trained on county care coordination and the relevant assessment processes. And they will coordinate with foster care liaisons at other managed care plans to notify them when members cross county lines and or need linkage to other health plans for the continuity of managed care plan services. And then finally, the Child Welfare Liaison will also serve as a family advocate as needed on a case-by-case basis. Next slide, please. Okay, so here what we have is a Child Welfare Liaison member story or vignette. And, you know, this is just sort of theoretical, right, to give you an idea for how the process can work. So we have an 11-year-old boy with ADHD, seasonal allergies, extremely swollen tonsils and adenoids, and severe sleep apnea in a foster home placement in County X. The minor is exhibiting behavioral issues within the placement home, as well as frequent non-compliant behaviors at school. The minor is receiving behavioral health services through County X Behavioral Health Department. He is participating in therapy and he is prescribed ADHD medication. The minor has an individualized education plan or IEP and is scheduled to have a sleep study as well as surgery to have his tonsils and adenoids removed within the coming weeks, right? The current resource parent is an older woman and it's a single parent home. She is no longer able to effectively deal with his home and school behaviors and reports not having the energy to provide him with the level of care and intervention that he needs. As such, she contacted the county social worker to give notice for him to be moved to a new placement. The county social worker schedules a child and family team meeting. The county social worker, through the MCP liaison, invited the MCP child welfare liaison to the CFT. At the meeting, the team discusses the minor's home and school behaviors, his medical needs, and scheduled appointments. The team also discussed the plan for the minor's placement change. The minor will be moved to a new placement in County Y. Minor will be moving to County Y in the next few days. County Y is a neighboring county to County X, and the MCP is a Medi-Cal provider in both counties. During the CFT, the managed care plan, child welfare liaison advises the team that they will enlist the health plan, transition of care team, and case management teams to support with the move and ensure that there are no issues with the minor's upcoming medical appointments. The transition of care team worked with the county social worker and the corresponding providers and hospitals to make sure that the necessary authorizations were submitted and processes and processed in advance of the minor's transition to the new home. The case management team assigned a care manager to the case, who the county social worker introduced to the new resource parent. The care manager served as the primary health plan point of contact for the new resource parent and the minor and supported them through the initial transition and completion of the medical appointments and procedures. The care manager offered to support with assignment to a new primary care provider if countywide, in countywide, if desired by the county social worker and or resource parent. The care manager also submitted an enhanced care management referral for the minor so that the ECM provider in the new county can step in and provide ongoing in-person support to the minor and the resource parent to help them remain connected with all services, behavioral health, primary care, any needed specialty care follow-ups, as well as support with any school-based services called out in the IEP. So that is sort of a vignette, if you will, example of how the health plan, child welfare, the various different liaisons, the health plan's transition of care team, as well as the case management team can work to support a child that has various different needs, but may also be in transition and moving to a different part of the county or a different county entirely. Next slide, please. Okay, so there's so much MOU information and so much information in the MOU that I kind of struggle with how much or how little to share. So this is what I came up with, right? With regards to the MCP child welfare MOUs, the Medi-Cal managed care plans, right? As many of you probably know, contract with the Department of Healthcare Services to provide high quality, accessible, and cost-effective healthcare through managed care delivery system, right? The MCP contract with DHCS requires us, the MCPs, to build partnerships with designated county departments, programs, and other third-party entities, right, to ensure members' care is coordinated and members have access to the community-based resources to support whole person care, right? So the MOUs are the mechanism through which we do that, right? These MOUs are intended to be effective tools to clarify the roles and responsibilities between the health plans and the county departments or programs or third-party entities, right? To support local engagement and the exchange of information necessary to enable care coordination, as well as improve referral processes and streamline access to services. So with regards to the child welfare MOU template, HealthNet is successfully collaborating with the other local health plan partners, as well as the child welfare departments in all counties or service areas to engage in these MOU discussions and execution efforts. So that's one of the successes, is that, this work is underway, right? And as the second bullet or check mark advises, right, the execution efforts are underway, and HealthNet has, to this point, successfully submitted 3 good faith effort MOU quarterly reports to DHCS. Those have been submitted and received and approved. No follow-up questions or concerns. So things are moving in the right direction. However, we have begin to identify a couple of challenges, right? And just things that we will have to continue to care for and work around. In many of the counties or service areas, there is substantial language changes, and it's really additional language being proposed to the DHCS template language, which it seems like will likely impact the execution timeline. And then the other thing is that in many counties or service areas, there's a somewhat growing concern one of the growing areas of concern post-execution, if you will, is around the requirements for information exchange or data exchange between the health plans and the child welfare departments. Okay, I'm gonna pause there for just a second to see if there are any verbal questions or to give the chat Q&A to get caught up. Baljeet, how are we doing for time? Or do we have time to go through the FAQs?
Yeah, I think we do. And your team has been responding to the questions in the chat itself. And we're going to capture all the questions that are asked either live during the presentation or part of the chat, and we're going to do an FAQ afterwards that will be posted on the CFPIC website.
Okay, awesome. All right. Okay, so yeah, let's jump into some of the frequently asked questions. And so what these are questions that we've received through just various different convenings, collaborations, MOU discussions and whatnot. And so we surveyed a lot of them, and these are kind of the most frequent ones to have come up. So we listed them here for you. So how can social workers or foster families check PCP assignment, right? If they call customer service on behalf of the youth, will the agent talk to a social worker? So the answer there is to speak with a social worker or foster family resource parent about member care. HealthNet will first need proof of dependency, placement, and or release of information naming those with whom we are authorized to speak, right? Now, this is best case scenario, right? But it would be great if the county child welfare or social workers could email the required documents 24 to 48 hours in advance of the outreach to the health plan if possible, right? The county child welfare / social worker will send correspondence to HealthNet child welfare liaison, which we also call our public programs team internally, to their designated inbox, right? The correspondence should be sent via secure encrypted email. And there's some suggestions here on the subject line. Should contain the first letter of the member name and member last name, followed by release of information. And as an example, is the J. Smith release of information. Body of email should contain member full name, date of birth, and benefit information number. Now, there's sort of two subcategories, one for child welfare social workers and one for foster families or resource parents. So county child welfare social workers should reach out directly to the HealthNet child welfare liaison, right? The HealthNet child welfare liaison or representative from the public programs team can provide that relevant information, right? The PCP assignment, et cetera, and support with any issues impacting care or service delivery. The county child welfare social worker may contact the HealthNet child welfare liaison or team via one of the following, right? There is going to be a designated inbox, which will be provided soon. And then there's also a designated dial-in phone number, which will also be provided soon. With regards to foster families or resource parents, slightly different, right? They should contact HealthNet member services. The member services representatives can provide relevant information and support, such as PCP assignment, support with changing PCP assignment, et cetera, right? The foster families or resource parents may contact member services via the following, right? And we have our member services number here listed as well. Any questions there before we move on?
Yeah, there is a question in the chat. With respect to these requirements, is there currently a standard form that HealthNet uses? Also, is there a way to expedite this process as some kids have immediate needs for services once they come into our child welfare system?
Yeah, sure. Yeah, HealthNet does have a standard release form. But I think at the local level in your MOU discussions, especially as it relates to other plan partners, we would be open to what makes the most sense for the county, right? Like it may make more sense for your form, right? If you have a form at the county level to be the form that is adopted for your county by all of the health plans, right? So yes, we do have a form. but we are not saying our form has to be the form used. It's the information that we need more importantly, right? And then there was a second part of the question. Is there a way to expedite the process? Yes, there is a way to expedite the process for sure. That's going to be on a case-by-case basis, especially for those kiddos who have immediate needs. And that's going to probably be through those instances where you dial in to the HealthNet Child Welfare Liaison directly, connect with someone in real time and take care of that, right? Like I said before, this is just sort of, perfect world, best case scenario response to those questions. Was there any other questions? No,
We do have another question. So some children pre-foster care are Medi-Cal managed care beneficiaries. However, upon removal into foster care, they are dropped from Medi-Cal managed care and put on fee-for-service. Have you seen this happen? And is there a way to maintain continuity of care?
Yeah, I mean, I'm going to ask Nancy to help me here a little bit. I think, Nancy, and I don't know if Ed is on either, but yeah, it seems right that happens, right? That the kiddo is on, let's say with HealthNet, right? And they are, placed in foster care, dropped from managed care, and placed on fee-for-service, right? Essentially, what I think we are working toward is a scenario where eligibility and the county would enroll that child with the managed care plan, right? And we would support you in identifying which of the health plans that child was enrolled with prior to coming into your care. But yes, I've heard of that happening, and I have seen that happen.
Right, and we know it varies by counties depending on sort of the practices, whether it be informal or formal practices of the county child welfare agency. And I don't know if Dr. Liao is on. I know we've been, oh, hi, Dr. Liao. I know we've been working very closely with LADCFS to sort of address that, but also to look at where we can first work at transitioning some of the like family maintenance program members into ECM.
Oh, we have a hand raised. We have a hand raised. Dr. Lau.
Hi, good afternoon. Thanks everyone for this very helpful presentation. I want to backtrack to ECM, just sort of the mechanics. If our social workers apply for a child to receive the ECM benefit, how is the child assigned to the ECM provider? Let's say if they don't have a provider who is also an ECM provider to their medical or their mental health provider.
That's a great question. We do have ECM providers who designate as serving the child welfare populations of focus in each county. And so depending on their capacity and their focus area. So for example, if the child comes in with, a mental health issue or substance use disorder, so we'll make sure that we're assigning the provider who has both expertise, right? Child welfare and SUD, serious mental health. And so, there is an assignment algorithm that we use. And of course, we vet the ECM providers who can serve our child welfare population of focus. Ideally, if you do have providers that you're already working with, the different county child welfare offices, I think that's ideal. We'd love to be able to contract with them for ECM. And that's the strategy we've been using, for example, in LA, right? Looking at who are the providers, so FQHCs or CBOs that you're already working with for family maintenance or, or other services. And then we can contract with them for ECM so they can add that additional wraparound and you get, one, so you're used to sort of that workflow already and they're providing a fuller scope of services for the member.
And then as a follow-up to that, how does the social worker find out that the child has been enrolled?
That's a great question. And because you can look it up if you're in the Medi-Cal system. So if the social worker, but that's not the case. And I think that's where the MOU comes in. Vernell, I don't know if that's getting addressed through the MOU, right, as part of the data exchange.
Yes, right. So is the question, how does the social worker identify that the member is enrolled in managed care, and B, with which managed care plan? Is that the
Enrolled in
question?
ECM, if they're
The
enrolled in
first
ECM,
question,
managed care.
the first part of that. So how does the social worker find out that the child has been enrolled in ECM? So
Okay.
let's say the social worker applies for it for the child, and then how does the social worker find out?
Yeah, no, yeah. So that will be that will be raised in two ways. One is the data exchange, right, that we hope to get to in several of our MOU discussions. Is the file format contains a report out on every member enrolled in ECM and which ECM provider and who those ECM provider lead care managers are. So there sort of will be a regular, monthly, weekly, whatever the designated frequency is between the health plan and the county file flow with that information, right? Also, that information can be accessed by virtue of contacting the child welfare liaison, like if you need it sooner than that. Does that answer your question? Thank you. Oh, okay. So I'll keep rolling through the frequently asked questions. So number 2, how does a social worker, resource family update the child or youth PCP assignment? And I think I talked through this a little bit before and in the vignette, but the county child welfare social worker may contact the Health Net child welfare liaison to do that. And there's more details, in the answer to the previous question. The foster families or resource parents may contact member services. So again, at that number above, the resource parents or foster families can contact member services and request for that updated PCP assignment. How can they find out which PCPs have availability? So this is the one scenario through which all parties would contact Health Net member services, right? So this would not be a situation through which the child welfare or social workers would contact the liaison team at the health plan. All parties will contact member services as the member services reps are able to perform that PCP availability check the quickest, the cleanest, and the most accurately. Okay, I was just reading the question in the chat. Can the child welfare liaison provide training or guidance on the referral process for social workers? Yes, the child welfare liaison can, or team, right, can support or join specific training specifically around how best to make referrals. Right, there's training and education requirements called out in the MOU, right, that specifically speak to the health plan and the county department collaborating to ensure that all of its staff and representatives understand what the roles and responsibilities of both parties are. And I do believe that includes, part of the training that you're calling out here, right? During like historic quarterly meetings, like we discussed trainings, we discussed, referrals and referral numbers and, barriers to care and things like that. And much of that discussion in some scenarios will lead to the identification of, oh, well, we need to work together to have a training on X or have a training on Y. And so absolutely, yes, that can be done. Where was I? Number 4. Okay. Can the MCPs create an expedited PCP assignment pathway for child welfare involved youth? And I'm gonna be honest, I think we've gotten probably that question most frequent. But we're not absolutely sure about whether or not this will be possible, but it is something that we are currently exploring and investigating and trying to see if there is a way for us to model so that is possible. So that is the one, not just yet, right? We're working on it. Number 5, does the MCP have a point of contact to help identify PCPs available to inform placement? How do we find out who this is? It's kind of question. Do you have a centralized inbox that could be used for information? What is the turnaround time for answering inquiries into that inbox? So as I indicated before, yes, we do have a point of contact, right? The point of contact will be an individual on the Child Welfare Liaison team. The HealthNet Child Welfare Liaison's names, designated inboxes, and dial-in info will be provided to you directly soon. That will be information that we will be providing, in, I would say, very near discussions, right? Like at the MOU level, at the county collaborative level. We were just checking on this the other day, and those numbers and inboxes are just about ready. The turnaround time for answering inquiries are as follows, right? The response there will be a response within 24 hours or 1 business day. But resolution, right? Just kind of note that a response means, that we'll acknowledge that we've received your inquiry, and that, and advise on, to a high level what we're doing to initiate resolution. But the resolution may take longer depending on the circumstances or the case specifics. I see a little red arrow. Let's see if that's another question. Oh, no. Okay. 6. What happens when a child moves placements and they are awaiting primary care provider change, right, to take effect on the first day of the next month, but they need to see a doctor ASAP, right? If the need is urgent, but it's not an emergency, the member can be seen at a local urgent care. If it is an emergency, right, then obviously we advise that the member should be taken to the ER. And that is covered, right, by the health plan. But what I'll flag here is, I think there's sort of a sandbox that's tied to the question 4, right? Can the MCPs create an expedited PCP assignment pathway? So, right, like if we are successful in our efforts to figure that out, and the ultimate answer is yes, we figured it out, this is how we can do that, then I think there's another bullet that can go to the question number 6, right? Is that yes, we can do an expedited assignment for urgent medical needs directly with an assigned PCP, I guess. All right, number 7, right? If they are in ECM and change placements or move to a new county, can they keep the same ECM provider? This will only be possible if the ECM provider is a regional or state provider, right? Since ECM best practice is to provide hands-on in-person support, right? The member will likely be transitioned to an ECM provider in the new county, a new ECM provider in the new county. However, that said, the current ECM provider, right, can support with the transition and linkage to a new ECM provider. That is in part of their scope and responsibilities as well.
We have another question, hand raised. Edgewell?
Do you know whether the ECM providers are comfortable facilitating child and family team meetings?
And again, Nancy, keep me honest here, right? But I would say that there may be some ECM providers who are child welfare contracted providers who have experience with facilitating CFTs. If that is the case, then by all means, right? I think yes. I think that just like the general standard ECM provider, I think would be open to it, but I think that would probably be something that would have to be discussed collaboratively, decided collaboratively, because, and correct me, Dr. Leal, because I don't know all of the specifics, but there are certain required elements, required protocols that go with the facilitation of CFTs. Is that not correct?
You know, I'm not 100% certain of
Okay.
that, but I think that's a potential role that one of the DHCS Populations of Focus newsletter had implied. So that's why I wanted to confirm.
Yeah,
I'll just jump in real quick to say, yes, there is an expectation from our state agency overseeing child welfare that we do CFTs to Fidelity. There's a CANS tool that may need to be updated in those CFTs. So I think your point is well taken that to do so would require some further discussion. Good to hear it's not impossible. And you are open to it and agreed. I think this is a really good point of conversation between the plans and counties.
thank you.
I think this is the opportunity, right? With the requirements of 1/1/2025, ECM providers can be that solution to that for that care coordination with the CFT team. So we want to be able to prepare our ECM providers for this. You know, we just conducted a survey of our LA County child welfare ECM providers, and you know, of course, you have those who are very much connected to DCFS, to DMH. I mean, they're already used to working with CFT teams, but it's a small, you know, number. And we have, you know, a lot more ECM providers who are FQHCs, you know, their local community clinics, and they want to be able to connect with the county child welfare counterparts, and they don't have that connection. That's been the theme of the survey is they don't have that connection. They're not able to connect with the member. There may be legal, you know, ramifications because really it's the county child welfare agencies who are the gatekeepers. You're the gatekeepers for the child. And it's really important for the ECM providers to first make that connection and relationship connection with their local child welfare social worker before they even contact the member. And I think that's the workflow we have to develop with the ECM providers. And that's how we can get them sort of maybe ready and assess readiness to be part of that CFT team.
And I think that might have been all of the FAQs. Was this for? I think you were going to give this an overview on this, Nancy, but I almost feel like we meant to put this in the appendix, but I could be wrong.
Right. Yeah, I think it's a reference document really looking at if you had questions about sort of the roles and responsibilities of, you know, health plans versus county child welfare agencies, ECM providers, or where we think the role, you know, kind of the delineation where we can support one another, right? ECM providers versus other providers and the members and the caregivers themselves. But, you know, one thing I did want to kind of emphasize and just through the chats is for ECM eligibility, I mean, essentially any child and youth that comes through your door will qualify for ECM. I mean, I think that's a safe statement, you know, instead of trying to look at, do they qualify because they're not in this program or that program. So DHCS has intentionally set the criteria, removed, you know, the need for children and youth, all children and youth under Medi-Cal from having like a diagnosed, you know, a complex health need. They don't have to have a diagnosed physical health or, you know, behavioral health condition. Whereas for the adults, when you look at the population focus for ECM as a criteria, they do, right? So for children and youth, they removed that criteria to really to be able to impact upstream, to, you know, be more prevention, right? Primary prevention instead of waiting for the child to you know, kind of show up with physical health or behavioral health conditions. So if the member is your children, youth can also fall under multiple population of focus. So they will qualify, you know, I think no matter what, if you have a child or youth with, you know, who's experiencing trauma, you know, who has an ACEs of 4 or more, which will be probably your entire, you know, population, they will qualify. So, and the same with community health workers. So I think, you know, think of it sort of more in sort of, you know, where it's not restrictive, right? Like we actually have underutilization of these services, these amazing services that we're now, you know, have a network for and are paying for. And so we really want to engage, you know, all of you who are serving your clients and your members to tap into these services and reach out to us if, you know, there are any questions. And I think the other component is we do not require prior authorization for ECM, for enhanced care management. So as long as you're identifying the member, you just route them to the ECM provider or route them to us. We're going to push it through. We don't require an authorization. We do for community support services for most of it right now. There's some that we are we lifted authorization like sobering center, but for ECM, no authorization.
All right, and I just want to stop, Baljeet, and do a check-in with you. Are we still good to proceed?
Yeah, I think so.
Okay.
Questions have been answered as they come up, either in the chat or in the live discussion, so we're good.
Okay, cool. So this is just super high level information regarding the transportation benefit that is available through the health plan, right? So the health plan provides 2 types of transportation for appointments, either non-emergency medical transportation, which is transportation by ambulance, wheelchair van, or leader van, or for those who cannot use public or private transportation, right? All NEMT or non-emergency medical transportation services require what's called a physician certification statement, which is a form that we use to validate the need for transportation and the level of service. The second type is non-medical transportation, or NMT, right? And this is transportation provided by private or public vehicle, which includes car, van, taxi, ride share, or mass transit. On the right-hand side is an overview of how to arrange a reservation, or how a reservation can be made for transportation services. The health plan, Health Net, contracts with Motive Care. Motive Care is our transportation vendor. There is advance notice required when arranging the different levels of transportation. So for non-emergency medical transportation, that requires 48-hour advance notice. For non-medical transportation, that requires 24-hour notice. Advance notice is not required for members who need to seek medical attention for the following urgent appointments and or treatment types: dialysis, chemotherapy, radiation therapy, urgent care, wound care, or discharges. However, the urgent trip requests can have extended wait times, given that it's happening in the moment, in real time. So those urgent trips may have a wait time that can take up to 4 hours to complete. We ask that when you call to request the trip, that you have the following information available when reserving a ride: the member ID, name and address of the doctor and or specialist, appointment date and time, pickup time, and address. And then there is a asterisk statement down at the bottom regarding Medi-Cal members being assigned to medical groups. But I think, well, I won't speculate, but assigned to medical groups responsible for arranging non-emergency medical transportation. When contracting Motive Care, they will essentially verify if the member is assigned to a medical group responsible for arranging these trips. refer the caller to the number on back of the member's card that is for that assignment to that specific medical group. So just want to flag that. And that brings us to the conclusion. So what we have here listed on the left are the regional leads for HealthNet. So at the top we have Harut Tarosian, and he covers the Calviva counties, right? So Fresno, Madera, and Kings. In the middle we have Kathleen Lang's contact information. She covers Imperial County for the administration of Community Health Plan of Imperial Valley. And then I'm Vernell Shaw III, as I said at the beginning of the call, the Medi-Cal regional lead for Northern California, and the counties that I cover are listed there: Amador, Calaveras, Inyo, Monos, Sacramento, San Joaquin, Stanislaus, Tulare, and Tuolumne. On the right-hand side, you have Nancy's contact information, and I don't think Ed was able to join us today. At least I didn't see him. If you're there, holler, speak up. But if not, Ed is over our is Director of Population Health, and he oversees the child welfare liaison team and the transition of care team. So I thank you all for your time today. I hope that you all found this information useful, informative, and helpful to you. I ask that you review the material and take it back with you to your local discussions with health plans, your MOU discussions. It'll come in handy when you start to have your joint policies and procedures discussions as well. But yeah, I thank you all for your time. Nancy, would you like to have any final words before we hand it back to Baljeet and her team?
I wanted to echo Vernell's gratitude for your time and attention today, and we'd love to hear from all of you and love to come in and do more in-depth discussion engagement with your teams to see where we can start connecting. Could be with our own teams, internal local teams, as well as your contracted local ECM providers and community health workers and others. I know we didn't talk about the other services, but there is such rich array of service providers that we can also connect your social workers to.
Great, thank you. And Dr. Liel has his hand raised.
Hi, thank you again. If a social worker is calling to arrange for transportation of the child and or family, will the social worker come up with any resistance in the sense that they're not a member?
Yeah, so in that scenario, there's two things. I think, similar to the question about just the general outreach, right? And having that release of information, right? That release of information can be provided to Motive Care so that they have it on file as well. The other place where we can list the social worker is on the PCS form information, so that it is just really, really visible to Motive Care when the social worker calls in that this is an approved individual who has the authorization to schedule a trip for a child, right? For all intents and purposes, it's, the way I see it is they are in a sense the dependents of the county, so the social workers are in effect the caregivers calling in, and so it would be treated in that same way. Is that helpful?
Yeah, that is. Is there a email address for Motive Care then?
So it would go through, you know what, Dr. Liao, can you drop your email address in the chat, and I will get back to you on that, because I think there is, in fact, I know there is, but some of the requirements from our vendor management or preferences from our vendor management have changed. And so I just want to make sure I don't give you, an email that you won't work for you, right? I want to make sure that I give you the right contact information for reaching out to them. We do have flyers for, like, if what you're asking is just for general scheduling of trips, we do have flyers and phone numbers, and they even have a mobile app now, like Uber. So it's pretty neat.
Great, thank you. Great presentation, a lot of great information, new information, I can say. When I feel like I know everything I need to know about CalAIM, and then I hear another nugget or nuggets. So this was great, really appreciate it. Just want to open it up to see if anyone else has a question that you didn't post in the chat or wasn't already asked. Please come off mute and ask your question. I know it's Friday, it's nearly 3:30, it's the long weekend. Well, I appreciate, oh, go
I'll
ahead,
jump
Diana.
in. Yeah, no, thank you. So Diana Boyer, CWDA again. You had mentioned an earlier part of your slide, and I know this is not the forum for, diving into the MOU, but you had mentioned earlier that you had seen the MOU that some counties had put forth and it had added some elements to it. Part of that includes and I'm just thinking about the ECM piece around that coordination across system partners and agencies that you see as part of the role of the ECM provider. And in the MOU is also reflected. In that MOU, there's discussion around AB 2083, which is the local interagency leadership teams that already include many other system providers. I'm just wondering if you've had time to reflect on that kind of system level coordination. There's work being done in a lot of the counties to prevent kids from staying in group home care, addressing their complex needs, and also even starting to work upstream. I'm wondering if HealthNet has had experience in working yet with these local interagency teams, if you've thought about it, if you have a reaction to that work, and how you see that playing out.
Yeah, so it is something that we are sort of dealing with, right? Like it is coming up in the discussions that we're having, right? We have in at least one county, I can say, begin to participate in that group and in that team. However, right, the additional language to the MOU, I'm just going to be brutally honest, is causing a little bit of angst, not just with MCPs, but just, it just seems like the additional language in any of the MOUs is creating some angst because folks are kind of looking at it like, well, is this something that should go into the regulatory document? Or is this something that should go into the joint PMP collaborative initiative, things that we will work on under the MOU space, right? And so I've heard and seen it coming up and being discussed in that way in a variety of different counties as well. The other thing to consider is that the health plans are having many of these MOU discussions in collaboration with one another, right? So you have multiple health plans in that same space, in that same conversation with the county department, child welfare department as well. And so everybody's really just trying to find like what is the best balance between what goes into the regulatory document versus what goes into sort of the policies, procedures, initiatives that we will continue to work on sort of space. What I will say is I haven't seen or heard of or been in discussions where it was like, we're vehemently opposed to, like it's just, I think it comes to, once the MOU is executed, the words that are in that document, right? They're edited and you know what I mean? And so I think there's some of that, but I don't know if that answers your entire question.
Well, you've definitely gone farther than I was hoping or expecting, I will say, but that is very helpful to hear. you know, there is what's the goal at the end of the day? And the goal at the end of the day is we're all working together to support kids and families, right? We're talking, we're communicating. And it is helpful to hear from the managed care side that the MOU is a regulatory document to which you are going to be audited. You're going to have to monitor for compliance. Like there's this level that maybe, you know, we need to understand better and appreciate. We've also heard the same thing from policies and procedures. And we've also started to hear terms like workflow, and other terms being used. So I think it'd be helpful at some point to just understand, like, what does it mean if it goes into MOU? What does it mean if it goes into a policy and procedure? What does it mean if it goes to, workflow and training? That was the other thing I think that was suggested too. And where does it best reside? Because, you know, we're starting I think what everyone is understanding is we're trying to build a working relationship. And this is the first step in a long road, and hopefully a long journey together of building up the support and services and coordination. So just know that there is an openness there and a willingness to learn in this process with you all.
Absolutely, absolutely. And you know, the thing that I've done in a couple of scenarios is create templates that I've shared with some of my team, and that they've shared with some of the child welfare around, like, you know, to your point, right? Like, this is what a joint policy and procedure template will look like, just kind of like the structure and bones of it. And this is, you know, and I'm happy to share it with you, right? And it's structured in such a way where it's like we can plug in the various different, under each MOU called out requirement, the various different ways in which we, the health plan, and the county child welfare will work together. And I think born out of that is where you get some of the more granular, in-depth workflows, right? Some of it may be health plan specific, right? Because you know, we may do things different than another health plan, vice versa. But I'm right there with you, right? You know, you talk to anybody that's been in a meeting, MOU meeting or discussion with me, that they'll tell you I'm as collaborative as I can be. You know, I'm trying to make it work. We have what, you know, upwards of 600 MOUs that we have to execute, right? So we have to get it done, right? We have to work together to do it.
Thank you so much. Dr. Liao, want to go ahead?
Yeah, Vernell, thank you so much for providing the health plan's perspective on the MOU. I definitely appreciate that, and I appreciate the partnership with HealthNet as well too. I see things slightly differently.
That's okay.
That the AB 2083 language, I feel like that should live in the MOU, and then the policies and procedures would really kind of spell out and define what that really means then in terms of the cadence and the meetings that that the health plan and the child welfare agency would be together at. That's how I see this. But again, I appreciate your perspective.
Yeah, Dr. Liao, listen, that, as I said, right, it's something that has come up and is just at various different stages of discussion in the various different MOU discussions that I'm privy to, right, is because there's like the italicized language, which is optional language, right? But then there's language that has been that has been added that wasn't previously in the MOU template. And I'm just saying that in the various different discussions that I'm aware of, and really the reason for bringing that up is just that it's going to impact the execution time frame. That was really the point. Is not so much to say that it shouldn't happen or whatever. I was flagging that, like, some of the specifics from the discussion are around what lives in the regulatory document or what lives in sort of a PMP or future initiative space, whatever you want to call it. But ultimately, that those details that are happening in those discussions are probably going to impact the execution timeline, right? So, like, I know we have a handful of MOUs that are already executed, right? I can tell you that those MOUs that are executed today, not child welfare, I should say. There is no no child welfare MOU executed, but we have some other required MOUs that we have to get executed that are executed. And by and large, most of those are ones where the template language that was included by DHCS is primarily the language in the MOU without a ton of optional language included or a ton of additional language included. So it just impacts the timeline. That's all.
Thank you.
All right, appreciate it. Great discussion, great presentation. Thank you again to our HealthNet partners. Thank you, county staff, for being here, leadership for being here on the call with us. The survey link is in the chat, but I'm going to send it out by email as well. Again, it helps us to kind of really look at where do